Okay, Professor Brett Manley is an iconic neonatologist and the inaugural Professor Director of Newborn Research at the Mercy Hospital for Women in Melbourne and the Department of Obstetrics, Gynaecology, Newborn Health at the University of Melbourne. He leads and collaborates on massive clinical trials to improve outcomes for sick newborn babies. Currently, he is co-leading the implementation of the PLATIPUS trial, and it's a world-first perinatal adaptive platform trial, hand-in-hand with the obstetricians, who are playing nicely to affect the outcome of preterm babies. Brett, to me, you're a very valued and respected friend. I hope you know that and feel welcome in Perth. We know we're your favourite too, okay? When you did the PLUS trial, we were the top second recruiter just by one patient, miraculously, in getting you there. But we look to you with so much admiration and respect. I know you could have worked with us some time ago. You turned us down for Melbourne. I'm personally really glad because everything you've achieved is just incredible, and you make the best of us look really, really slack. So it's lovely to see you, Brett. Welcome to Perth, and can't wait to hear your stuff.
Well, thanks so much, Tris. That was very, very lovely. And thanks to WIRF and to Matt and Deb, wherever you are, and Jackie up the back that drove me around this morning, and Vicky that put up with my emails, and the scientific committee. Thanks so much. I was very sorry to hear this morning that if you work at Perth Children's Hospital that there are dangerously high levels of lead in your drinking water. I don't know if you realise this. This was all over the radio in Perth this morning, so bad luck about that. So, Ben, you did mention the tap water in Australia, but apparently not at the Perth Children's Hospital. So I'm here to talk about Puggles and Premmies, and the platypus is a fantastic and fantastical creature. In 1798, Captain John Hunter, the second Governor of New South Wales, sent a pelt and a sketch of the platypus back to Great Britain, and George Shaw, the British naturalist, initially doubted its authenticity, Ben, and he believed the platypus might be a fake created by sewing together parts of different animals, like a duck's beak on a beaver's body. And there are only 5 species of monotreme in the world, and they're all in Australia. They are, of course, the platypus and the echidna, and monotreme meaning only one whole, and these are egg-laying mammals, truly amazing creatures. And cuteness overload, a baby platypus is called a puggle, and if you haven't seen a puggle before, this is what a puggle looks like. Of course, that is fake, and I've tricked you. That is not a puggle, but that's what you get if you Google puggle. This is actually a puggle. And of course, that's not really a puggle either. These are people online who are, you've got to be really careful these days. Actually, these are actually puggles. They look kind of like baby platypuses, so maybe not a big shock there. But you do have to be careful, don't you, Ben, with what you see online. So I'm here to talk to you today about something we've been working on now for 3 or 4 years, and I do so on behalf of an enormous team of people working across Australia and New Zealand on this initiative called the Platform for Adaptive Trials in Perinatal Units. Trish mentioned that obstetricians and neonatologists and midwives and everyone else are playing nicely together. My co-PI here is Claire Whitehead, an obstetrician. And I hope that some of the benefits of this platform go beyond just the research that we're doing in improving relationships and collaborations between all of us. So to think about why this is important, it's first important to think about the status quo. Clinical trials are really, really expensive, and they cost, the budget of the NHMRC is hundreds of millions of dollars, and they cost you all as taxpayers a lot of money. And to do one trial, for those of you who've done it, and it's getting more and more expensive, is at least several $1 million in our field, and probably more than that for a lot of our larger trials. They take a long time, and you end up waiting and waiting and waiting for the results. And you're probably familiar with this old paper about it taking, on average, 17 years for research findings to be translated into practice. Not necessarily in our field, but that's a famous analogy. And Trish mentioned the PLUS trial that was a trial of intratracheal budesonide for extremely preterm babies that took place all around Australia and New Zealand, including at King Eddie's. And that took us about 7 or 8 years from the moment we designed the trial to publishing it last year, and long-term outcomes in those babies continue. It's going to be about 10 years in total. This is a big problem, and even though trials are expensive and take a long time, a lot of them never finish, and that's an even bigger problem. So here's a study of all the clinical trials, not just from women and infants, in the Australia and New Zealand Clinical Trials Registry. In blue are those trials that were actually completed 10 years after they were started, and in orange are those that were never completed. So about a third of registered randomised trials are never finished. Here's a graph showing on average how long it takes to run a randomised controlled trial in the ANZ CTR across all specialties, and I've just highlighted there somewhere between sort of 3 and 5 years seems to be the most common, but also a long tail for a lot longer than that as well. And a lot of the studies that are being undertaken are underpowered, and nothing could be more true than for our field of women's and infants' health, where we commonly see trials that are underpowered and never able to show the effect that they want to see, or an important effect. And here's just showing the huge proportion of clinical trials registered in the ANZ CTR that are somewhere between 1 and 200 patients and pretty small. So the traditional way we've been doing clinical trials and randomised controlled trials has been this sort of fixed design, and you can think of that like a train track. You design your trial and you have to stick to it until the end. And in fact, that's one of the cardinal rules. You can't look at your data. You can't change what you said you were going to do. You must have the same primary outcome. You try and reach your sample size that you calculated before you started and hope you got it right. So then you conduct your trial, and hopefully you've got enough centres and collaboration that you actually finish your trial, and then you analyse it somewhere between 5 and 10 years later in our field, and you hope that whatever you did actually made a difference to our patients. And it's another sad truth that we are making only incremental gains in my field of neonatology and improvements with mortality and morbidity, like the big things like antenatal steroids, which I'll come back to, and surfactant. You know, they've come and gone, and it's unlikely we're going to see 50% reduction in mortality from one thing. Now, Brad stole my thunder because he gave you the analogy of Optus Stadium, but that's what I want to talk about again, because it's this idea of developing a trials platform, which is the P in APT, Adaptive Platform Trial. Once you design and build the stadium, it can be used for lots of things. You've got the infrastructure there. It all works the same every time. You can have footy there, and this is a picture of Fremantle beating my team, the Western Bulldogs, and I don't want to talk about it. And you can play cricket there, and you can have Tay-Tay there, and you can do all these things, and Tay-Tay didn't come to Perth, but never mind. So you can do all these things in the one stadium once you've got the infrastructure and you've built it. The A in APT is about adaptation, and this is the ability to change things, to take away things that don't work, to add new things as you move through the trial. And you can adapt lots of things within an adaptive trial. You can adapt what domains there are, which are what trials are in the platform. You can add them or take them away. Within those trials, you can add or subtract interventions, and you can compare more than 2 interventions at a time. You can change what population or subgroups that you're looking at. You can change your sample size. In fact, there is no pre-calculated definite sample size required, because in an adaptive platform trial using Bayesian analysis, you keep going until you get the answer, which is another really important thing that we need to be able to do. There are stopping rules that govern all of how this works, and ideally, and it would be great for us if PLATIPUS actually gets up and running and then can be perpetual, can keep going for a long time and have lots of different things added to it or subtracted from it. And this is not a new idea. Here's a paper looking at the number of adaptive platform trials that have been constructed and published over recent years. And if you look down here, year 2020, this is COVID, whooshka. Okay, all of these adaptive trials in infectious diseases and centred around COVID. This was a highly effective way of testing a lot of different interventions. But back all the way down here, oncology and infectious diseases have been doing these things for a long time. The REMAP-CAP trial was a trial that was started up in Perth. Steve Webb, one of its founders, has been helping us a lot with PLATIPUS. This is a trial that became very efficient during COVID and has answered a lot of questions and done a lot of comparisons, now has been able to pivot into the other ICU illnesses. But that's an example of a homegrown and very successful APT. But perhaps the perhaps the best known story of an adaptive platform trial was the recovery trial out of the UK. This is a newspaper article about how two professors got together on a bus when COVID was just kicking off in the UK and said, what are we going to do? We need some new trial methodology because people are starting to die and we're not ready. And they designed on the back of an envelope the recovery trial. This was all adult patients with COVID or suspected COVID. If you came into hospital, you were randomised into one of these 5 groups, which is a standard care or no additional treatment group, and then 4 different drugs that they were testing. And the primary outcome was death. So that's about as simple as you could possibly get, and a unique set of circumstances coming together, and very scary, of course. But very quickly, they had hundreds of hospitals across the NHS agree to be part of this trial. In fact, it really came from the top down, with government saying, right, you're all in it. We're going to fund this for tens of billions of pounds and we're going to get this done. And in an crazy example of efficiency, the first case of COVID, 31st of January 2020 in the UK, within 2.5 months, they'd had a patient die, but they had the protocol and everything approved and ready to go, and they'd enrolled their first patient within 2.5 months of the first case. Within a few weeks, they'd enrolled 1,000 patients in recovery, and a couple of months later, 10,000 patients in recovery, and they were already starting to see results from this adaptive platform trial within a month or 2 after that, including dexamethasone being beneficial, that immediately was translated into practice around the world. And of course, that was a really unique set of circumstances. There was an urgent need. Everyone worked together because they had to. There was immediate large-scale funding without even having to really apply for it. There were tens of thousands of eligible patients with a super simple, quick consent process. If you're admitted to hospital, you're in, and the simplest, most important primary outcome of death. So that's what happened in a pandemic when we really needed it to. But as others have already talked about, we have our own pandemic called preterm birth. So we know there's 13 or 14 million preterm babies born a year, about 1 million die. You've heard these numbers before. And a rate of preterm birth in Australia and New Zealand somewhere around 8 or 9%, higher in Indigenous populations, and around the world higher than that, around 10% on average. And you can see some of the horrific preterm birth rates in some of those countries on the top right there. And these are the actual numbers, 12 or 13 million preterm or very preterm infants, 600,000 extremely preterm babies a year around the world. And as a neonatologist and as obstetricians, midwives and everyone else in the room, we're trying to improve outcomes across this whole journey of preterm infants, from pregnancy before they're born to the moment of birth, all through their stay in intensive care if that's what they need, and up into childhood. And I know when I go on a ward round in the intensive care unit that I'm having to say I don't know a lot to myself internally or to people when they ask, because we simply don't know the answers to so many questions we need to know the answers to, and that's not without everyone in the room trying very hard to answer those. But this was just off the top of my head. I thought, what are some questions that we're still not fully across? Antenatal questions, birth questions, NICU questions, and these would all fit nicely in a randomised trial. And so across the top, I've thought about when you might be able to randomise pregnant women at risk of preterm birth and the babies themselves, including at the moment of birth or soon after, and then later in the NICU stay. So we've taken all this information and we've written about it. This is an article from a few months ago called Adapting to Survive and Thrive. And we spoke specifically about why the time is now for adaptive platform trials in our field of perinatology. And I'm sure I'll see some nods to these things because there's a history of pregnant women being excluded from randomised trials. You only have to go back as far as COVID to know that that happened systematically. We are excluding the tiniest, sickest babies from our randomised trials in neonatology. How stupid is that? I don't know what to do with a 23-weeker if they're not in your randomised trial to see if they had the potential to benefit. There are low recruitment rates. Most trials have under 50% recruitment. We need informed, usually prospective consent. That's bloody hard to get when they've just had a 23-weeker and it's 3 o'clock on a Sunday and it's very unpredictable. New interventions have modest effects and we just need to come to terms with that. Ben showed nicely all these dodgy trials that are going on, and a lot of our trials are powered to show things like 50% reduction in BPD. It ain't going to happen. We need large sample sizes and our trials take a long time. And traditionally, we've used dichotomous or composite outcomes for the very reason that we haven't had enough power in our trials. So we use outcomes like death or IVH or NEC or BPD as our primary outcome. And I think that has to change. And so does this. we need to work together as, well, I've just put obstetricians and neonatologists here because that seems to be where a lot of the politics is, but this is really important. How silly that obstetricians are doing trials without and picking neonatal outcomes without a neonatologist or paediatrician helping them. And the reverse is true. How silly that we would do trials of antenatal steroids and not ask obstetricians how to do it. Here's an example. Right now around the world, including in Australia, there are 5 large RCTs of antenatal corticosteroids going on. Where's Erin over there? She talked a bit about these issues today. And they are planning to recruit over 23,000 women. They all have different primary outcomes and different sample sizes. That's great, and I applaud them, and I know how hard it is to do this. But is there a better way? What if we had one control group and then we had a domain that was looking at the dose of dexamethasone and a domain looking at the dose of betamethasone, and we were able to analyse all the subgroups within the same platform, and all of these trials had exactly the same primary outcome? That could be great, and once we had answers to any part of this, we could move on to the next question. Okay, one dose is better, what about the next one? And the potential is there for less money wasted, quicker results, faster implementation into practice, and obviously comparable outcomes given they're the same. And that's where we've gone with the PLATIPUS trial design. This is an adaptive platform trial to assess interventions in pregnancy, that is in women at risk of preterm birth, and in preterm babies themselves, with the aim of improving outcomes for preterm infants. So the population that could be enrolled in PLATIPUS includes pregnant women at risk of preterm birth and the babies themselves. The setting is any maternity hospital that looks after preterm babies or women at risk of preterm birth. And we've got one primary outcome for every single trial within the platform, which we've called the PLATIPUS Ordinal Outcome Scale, and I'll come back to. And here's a short animation. Part of what we're doing as well is trying to make things more accessible for consumers, lived experience, but also for clinicians. This stuff is hard to explain.
Preterm birth, being birth before 37 weeks gestation, is the leading cause of death and disability in children under 5 years of age. 1 in 12 births in Australia and Aotearoa, New Zealand are preterm, and this rate is higher in Aboriginal, Torres Strait Islander and Maori populations, and in people who have recently migrated here. Introducing PLATIPUS, a platform for adaptive trials in perinatal units. PLATIPUS aims to improve health outcomes for babies born preterm. PLATIPUS has been designed by families who have experienced preterm birth, along with health professionals. The team includes Maori, Aboriginal and Torres Strait Islander committees and a group of parents, the Lived Experience Committee, who have a say in the studies we conduct and how we conduct them. Some studies within PLATIPUS will assess treatments given in pregnancy to those who are at risk of preterm birth. PLATIPUS calls these pregnancy domains. Other studies will assess treatments given to preterm infants shortly after they're born. PLATIPUS calls these neonatal domains. Some of the questions PLATIPUS may be able to help answer moving forward include: what treatments can we give to pregnant people before a preterm birth to improve the outcome for their babies? How and when should preterm babies be born to give them the best start to life? What are the best ways to care for preterm babies in the first minutes and hours after birth? What are the best ways to care for very preterm infants in the neonatal intensive care unit? Each domain will compare the effectiveness of therapies used to prevent, treat or manage complications in pregnancy or in preterm babies. Many of these are already used in hospitals. PLATIPUS is an adaptive platform trial, meaning we can continuously review each treatment within a study against a health scale and adapt in response to what the information tells us. As soon as we know one treatment is performing better, a set of decision rules will determine whether the study continues or if sufficient evidence has been generated to be sure of a conclusion. This may include the removal of poor performing medicine therapies or the addition of others. PLATIPUS hopes to have studies available in all maternity hospitals in Australia and Aotearoa, New Zealand. PLATIPUS aims to help improve access to research in pregnancy and preterm birth, and we will share our results with healthcare professionals, the wider community, and in journal publications, so that the outcomes can help to improve the healthcare provided during pregnancy and to babies born preterm. If you would like to know more, please scan the QR code, speak with your doctor or midwife, or email us.
So we really like these animations. We want to use them in consent processes as well. You know, you can imagine going into a hospital and being provided with an iPad clicking about information on the platypus trial. Do you want to hear more? Maybe click on this trial, and now I want to hear about that trial. So that's the way we're going. It all sounds great, but this has been very, very hard work, and to be honest, has taken a very long time and has cost a lot of money up until now. But we hope that the payoff will be in the long term. It's really complicated as well. I mentioned Bayesian analysis, and we've had to put together a team of statisticians and build their knowledge and confidence in Melbourne to be able to run huge trials like this. These are real bits of information that are in our trial core protocol. Don't ask me to tell you what that means or what that means, but this was a trial simulation where we tried to simulate a whole different set of circumstances in our antibiotic trial that I'll mention soon to make sure that we'd be powering the trial effectively, even though you don't have to come up with a sample size. And also the amount of governance and teamwork that goes into this is huge. So the concept here has been a collaboration between pregnancy and neonatal clinicians, between Australia and New Zealand, and between clinicians and those with lived experience. And so every single level across the platform and every part of each trial has representation like that. We're very proud of the amount of work we've gone into lived experience here. This is Melinda Cruz, some of you will know, from Sydney, who is on our trial steering committee, was the chief investigator on the grant and runs the lived experience committee. But we also have Aboriginal, Torres Strait Islander and Maori committees as well. We've been looking into new ways of doing consent and ethics, because for those of you that have had to consent mothers at 3 o'clock in the morning with a 45-page consent form, you know how ridiculous that is. We're looking at health economics to see whether this is actually efficient, and we're looking at how we're going to follow up all these babies as well. And that's required a lot of upfront funding, a bit like the recovery trial. So we hope that over time the amount of funding required will diminish and that will be a good thing. But we've had to get 4 big grants just to get to this point of just about being ready to randomise some mothers and their babies. And we spent a lot of time thinking about what the one single outcome is going to be for every single trial you could possibly do about preterm infants. So we need one outcome for all comparisons, no matter whether you're interested in hypoglycemia in a 36-weeker or mechanical ventilation in a 22-weeker. It needs to be simple. It would be great if it could just be death, but in higher... I didn't mean that, you know what I meant. It would be simple. It could be a dichotomous outcome like death. However, in high-income countries, we simply don't have enough of that, which is brilliant. But you can't use that as a primary outcome because there won't be enough data. So it's got to be simple, but also realistic. And it has to be able to cater for all the different types of pregnant women and infants that would be in the trial. So we've come up with this ordinal outcome. And this is, again, not new. We haven't made this up ourselves. There's lots of ordinal outcomes being used in all sorts of trials across different fields in medicine. Again, here's another example of a collaboration between multiple APTs in adult ICU medicine, including the REMAP-CAP trial I mentioned before. And they come up with these Bayesian statements. It's a little bit of a different way of thinking, but the probability that therapeutic anticoagulation increased organ support-free days was about 99%. So no p-values here. It's quite a different way of coming at these problems, and we're all going to have to learn about it. Here's the primary outcome we've spent several years developing. This is an outcome from best to worst, which we're calling the PLATIPUS ordinal outcome. So this covers all of preterm birth, we hope, from none of these things happening to some less major bad things happening down to major things happening and down to death at the bottom. And it's actually a 15-level scale. I'll show you, flash it up in a minute. You don't need to see all 15 levels. But the idea here is that every single preterm baby that is born within platypus will fit somewhere. They go down to where the worst thing that's happened to them is, and that's the level they're included at. That means every single baby that's in the trial gives information to the primary outcome. We're trying to use routine collected data. We've got lots of consumer and clinician input, and we've tried to come up with ways of making sure these predict longer-term outcomes, because you can't wait 2 or 3 years for longer-term outcomes in an adaptive platform trial. So here's the actual full trial in more detail with the 15 different levels. We've got things that happen to late preterm babies, or hopefully don't happen to late preterm babies. We've got things that might happen to very or extremely preterm infants at the bottom. And we've got things that we think very closely will reflect longer-term outcomes. And we've done a lot of our own scoping work around this, building statistical expertise and publishing as we go. And of course, now we're validating the primary outcome in lots of different actual real-world trials. And here's an example of data from the VICS Victorian Geographic Cohort of extremely preterm babies. This is a made-up zombie trial. Ben, this is a zombie trial of antenatal steroids versus no antenatal steroids. It's not a real trial, but we've used the cohort of babies that was within that trial to create this. Here's a stacked bar chart showing from left to right outcomes that are getting worse. So the dark red is death and everything to the left is the other stuff. And that's what it looks like with no antenatal steroids at the top. That's what it looks like with antenatal steroids at the bottom. So this is not new news. Antenatal steroids are good. You can clearly see that they dramatically increase survival, and that's demonstrated in this stacked bar chart. But you can also see that there are adverse outcomes different between the two. Minor adverse outcomes are also very different between the groups. And then when you analyse this with a Bayesian analysis, you see we're 99% sure that antenatal corticosteroids are good for you and they dramatically improve health, the odds ratio of 0.44 there. So our first two domains and trials are ready to go. This is again AI on the right-hand side, but the first neonatal trial is the Baby Chino trial, looking at doses of caffeine citrate for very preterm infants. For anyone in the room that isn't aware, caffeine is one of the most frequently used drugs in very preterm infants, incredibly safe, short and long-term benefits, and recommended by the WHO for everyone born very preterm. And it comes from this caffeine for apnea prematurity trial by Barbara Schmidt and colleagues, including Australia, which is now 20 years old, where they used these doses of caffeine, a loading dose and a maintenance dose, and showed a reduction in BPD and improved longer-term outcomes. And now everybody uses caffeine. But there's quite a bit of evidence accumulating that we should or could be using higher doses than were tested in that trial. And the science behind the doses used in that trial wasn't that fantastic, and they didn't measure caffeine levels in the trial either. So this is a Cochrane review showing that higher dose compared to lower dose caffeine may reduce BPD, and we need to study it. So we surveyed all of Australia and New Zealand and got 117 neonatologists to tell us what they were doing. And I've just highlighted here the proportion of doctors already prescribing higher doses than we used in that randomised trial. This is clinical creep, where people think some of caffeine's good, let's give more caffeine. And in fact, in Brisbane, they've been giving 4 times the dose used in the CAP trial for many years, decades. So we aim to compare the efficacy and safety of higher, medium and standard dose caffeine in very preterm infants. This is what it's going to look like. Don't need to go into too much detail here, but there's basically a double the dose, a 1.5 times the dose and a standard dose. And this is the sort of thing that you can answer in an adaptive platform trial. As soon as you know that one level is inferior, you can drop it and add another one or keep going until you get the answer with the last 2. And of course, to get people to join these trials, you've got to go around begging centres to join your trials, and that hasn't changed over the decade and a half I've been doing it. This is me and Jennifer Dawson in 2017, coming to King Eddie to see if they'll join our Plus trial, which they did and contributed almost 150 extremely preterm babies. This is me yesterday. You can see in 7 years, fatter, balder, more disillusioned. So actually, same backpack, I realised, which is... I really should wash it. The first pregnancy domain, so we're going to have a neonatal trial and a pregnancy trial running at the same time and potentially in the same patients. This is the PROMOTE trial of which antibiotics we should be using for PPROM. Such a common question, but believe it or not, we really don't know what we're doing with prescribing prophylactic antibiotics for women who present in preterm ruptured membranes to prevent infection. And in fact, we've surveyed that as well. And we've got 3 common regimens across Australia and New Zealand. That's azithromycin alone, erythromycin alone, or the combination of erythromycin and penicillin. That's great, but there was 90 different ways that these drugs were being prescribed just in our hospitals in Australia and New Zealand. That is stupid. So here's how a trial this is how it might look in an adaptive platform trial. Women come in with PPROM, randomised into one of 3 groups. We analyse the data till we get an answer. You drop the one that's not as good, you keep going, or you add a different antibiotic regimen and you keep going round and round until you find the optimal one. All of these things take a huge number of partners and collaborators, and here are just some of them, including several from Western Australia that we're so proud to be partnering with. We've got a website if you want to read more about the PLATIPUS trial, and thanks very much for listening.